Welcome to our video on kidney blood flow and structure. It is important to learn about renal blood flow and how different factors can affect renal blood flow because this determines how well the kidneys can filter blood to get rid of metabolic wastes and control electrolyte and water balance. As you will learn later in this course, in the diseased state, different structures within the kidneys can be affected, so we will introduce you to the different structures within a single nephron unit. As the kidneys filter 144 liters or 38 gallons of blood into the urinary collecting system daily, they need to have a mechanism to reabsorb most of this fluid. This is where the countercurrent multiplier system comes in. And finally, we will discuss how the blood is separated from the urinary collecting system by a three-layer barrier called the glomerular filtration barrier. In the diseased states where the different layers can be defective, patients may present with different clinical manifestations, categorized as either nephrotic or nephritic syndromes. We will discuss classic clinical manifestations associated with these syndromes and introduce common conditions that typically present as nephrotic or nephritic syndromes. Let's first discuss kidney blood flow. Here we have our kidney, cortex on the outside, medulla on the inside. The renal artery branches off from the aorta, which then branches off into segmental followed by lobar arteries, interlobar, arcuates, and interlobular arteries, which are tiny arteries that penetrate the renal cortex. Let's zoom in to one interlobular artery. The interlobular artery further branches off into many smaller arterioles that coil up, referred to as glomerular capillary tuft. This is where the blood is filtered to get rid of metabolic wastes and water into the urinary collecting system. The urinary collecting system starts with a filtrate collecting cup-like structure called the Bowman's capsule, which drains the filtrate into the renal tubules for further exchange of electrolytes and other solutes to make the final product called urine. The incoming arteriole to the glomerular capillary is called afferent arteriole, and the outgoing arteriole, efferent arteriole. After filtration occurs in the glomerulus, the efferent arteriole leaves the glomerulus and becomes peritubular capillary, where it delivers nutrients and oxygen to its own tubule. Once done, the peritubular capillary returns blood back into the venous system via the venule, interlobular, arcuate, interlobar, lobar, segmental, then renal vein and inferior vena cava. The globular structure here with the glomerular capillary tuft and Bowman capsule is called a glomerulus. There are approximately 1 million glomeruli in the cortex of each kidney. The glomerulus, together with its own collecting tubule, is called a nephron. Here we have our kidney on a flat page, cortex on top, medulla at the bottom. The more superficial part of the cortex is also known as the outer cortex. The middle portion is called the corticomedullary junction. Recall we have the arcuate artery running along the corticomedullary junction, which branches into interlobular arteries followed by afferent arterioles, which form glomerular capillaries, then leave the glomerulus as efferent arterioles, then feed their own tubules as peritubular capillaries. As it turns out, not all peritubular capillaries are equal. Glomerular capillaries that are located in the deep cortex or adjacent to the corticomedullary junction extend straight deep into the medulla along their own collecting tubules. These long peritubular capillaries are called vasa recta. Vasa recta perform a special and very important function which we will discuss later. Renal blood flow and glomerular filtration rate are determined by autoregulation and neurohormonal factors. Autoregulation is thought to involve two processes called the myogenic reflex and tubuloglomerular feedback. Major neurohormonal regulators include sympathetic nerve activity, angiotensin II, atrial natriuretic peptide, prostaglandins, and dopamine. What is autoregulation and what is its purpose? Autoregulation is a process that ensures optimal blood supply to the kidneys and optimal glomerular filtration rate over a wide range of blood pressures. It is not neurally mediated since it is also present in the denervated transplant kidney. Before we talk about the myogenic reflex, we need to define renal blood flow. Renal blood flow is defined as mean arterial pressure, or MAP, times the radius of the afferent arteriole. Essentially, the gatekeeper for renal blood flow is the afferent arteriole. This should make sense because the greater the systemic blood pressure, or MAP, the bigger the radius of the afferent arteriole, the greater the blood flow into the glomerulus. So now what is a myogenic reflex? Here we have the afferent arteriole going into the glomerulus and leaving it as the efferent arteriole. What happens if there is very high blood pressure sending high blood flow into the glomerulus? This would expand the glomerular capillary bed and increase glomerular filtration. The high blood flow and pressure can lead to endothelial damage within the glomerular capillary bed that can lead to arteriosclerosis and glomerulosclerosis, or scarring of the glomeruli. In the presence of high systemic pressure, afferent arterioles reflexively constrict to protect glomeruli from intraglomerular hypertension and injury. The myogenic reflex automatically reduces blood flow through the afferent arterioles when there is high systemic pressure. What is tubuloglomerular feedback? Shown here is the little glomerulus with the afferent and efferent arterioles and its own urinary collecting system starting at Bowman capsule, proximal tubule, descending limb of Henle loop, thick ascending limb of Henle loop. A specialized segment with macula densa cells, distal convoluted tubule, then collecting tubule. Macula densa cells are specialized cells in the wall of the distal end of the thick ascending limb of Henle loop, where it is surrounded with extraglomerular mesangial cells. Macula densa cells can sense how much chloride is being delivered to this part of the tubule. High chloride delivery to this segment implies glomerular filtration rate is too high, while low chloride delivery implies low glomerular filtration. Upon sensing the amount of chloride delivered, macula densa cells communicate this information back to surrounding cells to adjust the vascular tone of the afferent and/or efferent arterioles to readjust the glomerular filtration rate. The macula densa, afferent and efferent arterioles, and extraglomerular mesangial cells make up the juxtaglomerular apparatus. Let's see how tubuloglomerular feedback works. Imagine we have high blood flow going into the afferent arteriole. This results in high glomerular filtration, thus high sodium and chloride delivery to the macula densa. The macula densa senses the high chloride delivery and sounds off the alarm to neighboring cells within the juxtaglomerular apparatus, or JGA. JGA responds by constricting extraglomerular mesangial cells around the afferent arteriole to reduce its blood flow. This leads to reduced glomerular filtration, thereby reducing chloride delivery to the macula densa. Now imagine we have low blood flow going into the afferent arteriole. This results in low glomerular filtration, thus low sodium and chloride delivery to the macula densa. The macula densa senses low chloride delivery and sounds off the alarm to neighboring cells within the JGA. The JGA responds by vasoconstricting the efferent arteriole, thereby increasing intraglomerular filtration pressure to squeeze out more chloride to be delivered to the macula densa. Here is just a more detailed and enlarged picture of the JGA. We have the glomerulus, afferent, efferent arterioles wrapping around the distal portion of the thick ascending limb of Henle loop, where macula densa cells are found. Let's take a closer look at the juxtaglomerular apparatus. We start with blood from the afferent arteriole flowing into the glomerulus, where plasma is filtered into Bowman capsule. The remaining blood leaves via efferent arteriole. Here we have interposed mesangial cells within the glomerulus. Filtered chloride drains down the distal end of the thick ascending limb. Here there are specialized cells called macula densa. These cells can sense the presence of chloride delivered to the segment. High chloride delivered signifies high glomerular filtration. To avoid continuing high chloride loss into the urine, extraglomerular mesangial cells in the renal interstitium contract to vasoconstrict the afferent arteriole to reduce blood flow through afferent arteriole, thereby reducing glomerular filtration and subsequent renormalization of the degree of chloride and accompanying volume loss. On the other hand, when there is low chloride delivery to the macula densa, juxtaglomerular cells, which are modified cells in glomerular arterioles, secrete renin to increase the synthesis of angiotensin II. Angiotensin II vasoconstricts efferent arteriole to increase the intraglomerular filtration pressure. This effectively increases the filtration of sodium chloride to drain down to the macula densa, thus effectively re-establish the normal level of chloride and accompanying volume excretion. The purpose of tubuloglomerular feedback is to maintain a relatively constant glomerular filtration rate. Of note, juxtaglomerular cells also secrete renin in response to low preglomerular pressure seen in patients with poor blood flow to the kidneys and sympathetic nerve stimulation. We have other regulators of renal blood flow and glomerular filtration. Again, now afferent arteriole, glomerular capillary, and efferent arteriole. Sympathetic nerve activity stimulates alpha-1 receptors to cause vasoconstriction. Since there are more alpha-1 receptors on the afferent than efferent arterioles, sympathetic nerve activity will predominantly cause vasoconstriction of afferent arterioles. Angiotensin II vasoconstricts efferent arterioles. Prostaglandins vasodilate afferent arterioles. Dopamine also vasodilates afferent arterioles at low level. In the old days, we used to use low-dose dopamine infusion to increase renal blood flow in patients with poor kidney function. However, since there are no data to support improved renal or survival benefit, this practice is no longer used. Last, we have atrial natriuretic peptide, also known as ANP, which vasodilates both afferent and efferent arterioles but more so for afferent than efferent arterial. Let's apply our knowledge to different clinical scenarios. Here we have normal blood flow and glomerular filtration. What happens when there is low blood flow through afferent arterioles, such as that seen in patients with volume depletion, hypotension, or the use of NSAIDs? When blood flow through afferent arteriole is reduced, angiotensin II is increased to vasoconstrict efferent arteriole to restore intraglomerular filtration pressure, thus glomerular filtration. Because of the angiotensin II protective effect in these conditions, the use of any inhibitor of the renin-angiotensin system is avoided. In fact, in the critical care setting, when there is severe hypotension associated with sepsis, synthetic angiotensin II may be used. Let's look at another clinical scenario. What happens when we have glomerular hyperfiltration or when we want to reduce glomerular filtration pressure to protect the glomeruli from working too hard? Examples include glomerular hyperfiltration in the diabetic kidney, or chronic kidney disease where the reduction in intraglomerular filtration pressure may be protective. How do we reduce intraglomerular filtration pressure in these conditions? Recall angiotensin II keeps the efferent arteriole constricted. Because of this, if we block angiotensin II, we can loosen up the efferent arteriolar vascular tone. This will reduce intraglomerular filtration pressure. In glomerular hyperfiltration, inhibitors of angiotensin II are used to reduce glomerular filtration pressure. It is important to understand renal blood flow and regulators of afferent and efferent arterioles because renal blood flow supplies blood, oxygen, and nutrients to the kidney tissues, and renal blood flow and regulators of afferent and efferent arterioles determine how much blood can be filtered for fluid and waste removal, that is, glomerular filtration rate. Moving on to the urinary collecting system. We've discussed blood flow and regulation of blood flow and glomerular filtration. Now we switch to the urinary collecting system. After the plasma is filtered at the glomerulus, the filtrate is drained into the Bowman capsule, which then drains into the proximal tubule, thin descending limb, thin ascending limb, and thick ascending limb of the loop of Henle, distal convoluted tubule, connecting segment, collecting tubule, then larger collecting ducts. Each of these tubular segments have their own specialized functions, as we will learn later in the course. For any molecule to end up in the urine, it depends on whether it is filtered through the glomerulus, reabsorbed, and/or secreted by renal tubules. Now, continuing with the urinary collecting system, what happens to the filtrate after it is drained into collecting tubules? Collecting tubules from different nephrons join into bigger collecting ducts to drain into papillary tubules, seen here in these pyramid-like structures, which then drain into minor calyces, major calyces, renal pelvis, ureter, bladder, then out as urine. The junction where the renal pelvis drains into the ureter is called the ureteropelvic junction, and the junction where the ureter drains into the bladder is called the ureterovesicular junction. It is important to know the different levels of the collecting system so we can communicate with urologists and/or radiologists the exact location of a stone, cancer, or procedure. The rounded tips of these pyramids are called papillae. As these are localized in deeper portions of the kidneys, nutrients and oxygen supply are relatively depleted compared to outer cortical areas. For this reason, the papillae are highly vulnerable to ischemia and infarction whenever there is local oxygen deprivation. Infarction of papillae is called papillary necrosis and have been described in patients with sickle cell disease, diabetes mellitus, chronic use of NSAIDs, obstructive uropathy, among others. Once papillary necrosis occurs, the whole papillae may slough off and falls into and obstruct the urinary collecting system, oftentimes at the ureteral level. Finally, the regions where renal cortices extend deeper into the medulla in between the pyramids are called columns of Burton. Did you know that both kidneys filter approximately 144 liters or 38 gallons of plasma daily? But we don't make that much urine in one day. So how do the kidneys reabsorb back most of the filtered fluid? This takes us to the counter-current multiplier in the medulla. The counter-current multiplier is found in the medulla. The loop of Henle and vasa recta are major components. Let's take a closer look to see how this works. The thin descending limb of Henle loop is permeable to water. Water leaks out into the medullary interstitium. This process leads to increased tonicity within the lumen of the thin descending limb. The descending limb then loops back into the thick ascending limb. At the thick ascending limb, sodium and chloride are actively pumped from the lumen into the medullary interstitium. At this segment, the tubule is impermeable to water. What this means is, while the osmolality of the medullary interstitium is built up, the filtrate within the lumen becomes more and more dilute because water cannot leak out. The dilute filtrate then travels to the distal convoluted tubule, then down the collecting tubule. At the collecting tubule, water can seep across the lumen into the medullary interstitium. Water reabsorption here is facilitated by the high osmotic gradient that was built within the medulla. What about all of these electrolytes and water that are reabsorbed into the medullary interstitium? How do they return to circulation? Remember the vasa recta or peritubular capillaries from juxtamedullary glomeruli? They scoop down into the medulla and carry electrolytes and water back into circulation in a counter-current manner. Essentially, the high medullary concentration gradient formed by the counter-current multiplier is used by the collecting duct for effective water reabsorption. Moving on to other structures within the kidney. Here is our kidney. All glomeruli are located in the cortex. If we perform a kidney biopsy across the cortex, we will see glomeruli, tubules, and the interstitium. Looking closer at the glomerulus, we see the afferent arteriole and the efferent arteriole. The filtrate from the glomerular capillary drains into the Bowman capsule, which then drains down the tubule. We can see cross-sections of the glomerular capillary tuft, seen here as empty circles, also referred to as capillary loops. The pinkish matrix surrounding the capillary loops is the mesangium with its mesangial cells. We've discussed both the blood and urinary collecting sites. Now we take a look at what separates these two sites. This takes us to the topic of glomerular filtration barrier. The layer that glues the glomerular capillary loop and the urinary collecting system together is called the glomerular basement membrane, commonly abbreviated as GBM. The glomerular capillary wall, glomerular basement membrane, and epithelial cells lining the urinary collecting site make up the glomerular filtration barrier. Taking a closer look at the glomerular filtration barrier. Starting with the glomerular capillary with its fenestrated endothelial cells, glomerular basement membrane in the middle, epithelial cells from the urinary site called podocytes stretch out into finger-like projections over the GBM to prevent passage of big molecules such as albumin from the plasma into the urinary space. These finger-like projections are called podocyte foot processes. Foot processes of neighboring podocytes interdigitate with each other, leaving filtration slits that are bridged by extracellular structures called slit diaphragms. On electron microscopy, glomerular endothelial fenestrations may be seen. Endothelial fenestrations are pores filled with negatively charged sialoglycoproteins. The fenestrated capillary endothelium prevents passage of molecules greater than 100 nanometer and blood cells into the urinary space. The GBM itself is composed of type 4 collagen, consisting of alpha 3, 4, and 5 chains, laminin, fibronectin, and polyanionic proteoglycans, such as heparan sulfate proteoglycans. On the urinary side, the luminopodocyte membrane and slit diaphragms are also covered with negatively charged sialoglycoproteins. The molecular composition of the slit diaphragm is complex. Known proteins at the slit diaphragm include nephrin, p-cadherin, FAT1, and podosin. Slit diaphragm proteins connect podocyte membranes to the cytoskeleton, which includes myosin, actin, and alpha-actinin 4, all interacting to provide the structural integrity needed to prevent passage of large molecules such as albumin into the urinary space. Passage of any molecule across the glomerular filtration barrier depends on its size. Fenestrated capillary endothelium prevents passage of blood cells and molecules greater than 100 nanometer. Albumin, which are bigger proteins, only pass through the glomerular filtration barrier in minute amounts. Because the glomerular filtration barrier is coated with negatively charged proteoglycans, molecules of same size and shape exhibit different permeabilities depending on their electric charge, with negatively charged molecules being less permeable and positively charged molecules being more permeable than neutral molecules. Albumin and most plasma proteins are negatively charged and are normally minimally filtered. Water and small molecules, such as low molecular weight proteins, can pass through the glomerular filtration barrier freely. Here we have healthy podocytes that can act as a fence to prevent the loss of large molecules such as albumin into the urine. Here there is foot process injury, described as foot process effacement. This may be compared to a broken fence where large amounts of proteins and albumin can be filtered and lost into the urine. Defects or mutations of genes encoding podocyte structural proteins, a direct injury to podocytes or glomerular basement membrane, can lead to severe proteinuria and the development of nephrotic syndromes, where patients present with edema, severe proteinuria, hypoalbuminemia, and hyperlipidemia. Examples of nephrotic syndromes include minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis, diabetic kidney disease, amyloidosis, and in some cases of glomerular diseases with the membranoproliferative pattern of injury. Defects or injury involving glomerular capillaries, glomerular basement membrane, or mesangium can give rise to nephritic syndrome. Nephritic syndrome is characterized by having an active urinary sediment. That is, red blood cells can be seen in the urine analysis. In very active disease, a large number of red blood cells can be excreted into the urine in the form of tubules, referred to as red blood cell casts. Some patients may have accompanying hypertension. Unlike nephrotic syndrome, patients with nephritic syndrome typically present with low-level albuminuria and proteinuria, an absence of hypoalbuminemia or hyperlipidemia. Common conditions associated with nephritic syndrome include vasculitis, antiglomerular basement membrane disease, lupus nephritis, IgA nephropathy, post-infectious glomerulonephritis, and glomerular diseases with a membranoproliferative pattern of injury from various causes. This slide shows the different clinical manifestations and conditions associated with nephrotic or mesangium versus nephritic syndrome. Nephritic syndrome. We will discuss more about nephritic syndrome is characterized by having an active urinary sediment. That is, red blood cells can be seen in the urine analysis. In very active disease, a large number of red blood cells can be excreted into the urine in the form of tubules, referred to as red blood cell casts. Some patients may have accompanying hypertension. Unlike nephrotic syndrome, patients with nephritic syndrome typically present with low-level albuminuria and proteinuria, an absence of hypoalbuminemia or hyperlipidemia. Common conditions associated with nephritic syndrome include vasculitis, antiglomerular basement membrane disease, lupus nephritis, IgA nephropathy, post-infectious glomerulonephritis, and glomerular diseases with a membranoproliferative pattern of injury from various causes. In summary, we've discussed renal blood flow and regulators of renal blood flow and glomerular filtration, including the myogenic reflex, tubuloglomerular feedback, afferent and efferent arteriolar vascular tone, anatomy of the kidney, the single nephron, and the glomerulus, components and clinical significance of the countercurrent multiplier, components and clinical significance of the glomerular filtration barrier, and nephrotic versus nephritic syndromes when different components of the glomerular filtration barrier break down. The end.